you, everybody, for attending today. Today I'm going to talk about prescribing buprenorphine in primary care, and we'll talk about some of the obstacles that people have in prescribing buprenorphine and getting treatment disseminated into urban and rural areas of the United States. So we're going to be talking about opioid use disorders, the prevalence. I think everybody who's here recognizes that we have an opioid crisis in the United States right now, and you've probably heard and seen this on the news about the number of people who are affected by opioid use disorder. Also talk about the unmet needs of people with opioid use disorder, provide information on buprenorphine, and discuss some barriers to buprenorphine being prescribed, as well as talk about some model programs that have been implemented to improve access to treatment. And then lastly, talk about some overdose risk factors in naloxone. So this graph here is from the Substance Abuse and Mental Health Services Administration, and this is from the survey that's done every year, the National Survey of Drug Use and Health, asking people about their substance use and their treatment. And what you see here is that about 2.14 million people are affected by opioid use disorder in 2016, and that's about 0.8% of the population. And this included people using heroin as well as pill opioids. And what you can see here is that of those people who are affected by opioid use disorder, not that many people are receiving treatment. Only about 1 in 5 individuals with opioid use disorder received any kind of specialty treatment for illicit drugs. And when you look at specialty treatment, that means going to an inpatient program at a hospital, an outpatient or inpatient drug and alcohol rehab, or treatment at a mental health center. So when they broke down the specific numbers from illicit drugs to heroin, about 37.5% of those respondents received treatment, whereas 17.5% who were using pill opioids were receiving treatment. And you see that people using pain relievers or opioid pills is a higher number and percentage of the population than those using heroin. One thing to note is that at specialty care facilities, such as these rehabs, hospitals, mental health centers, only about 27% of those facilities offer buprenorphine for treatment. Now, sometimes people aren't receiving treatment for drug and alcohol use because they don't feel that they need treatment. And you see in this graph here, this is all illicit drug users. About 93% of people said they didn't think that they needed treatment, and that's why they didn't go. Some people did try to get treatment or thought they needed treatment, and they made an effort. That's about 4% of the population affected, whereas about 3.2% thought that they needed treatment but didn't make an effort. Now, some of the reasons that they cited when they were asked about why they didn't seek any treatment was that they weren't ready to stop using. So about 38% said that. And in this graph, respondents could say several of these things here too. And there are some responses that aren't listed on here as well. Another big reason was they didn't have any health care coverage to seek treatment. They didn't know where to go. They couldn't find a program that could offer them what they wanted. Worries about stigma and affecting their people's opinions of them, and also having a negative effect on their job. And you see these two things here where primary care could really come in. People can go to their primary care providers if they're certified to prescribe buprenorphine and get treatment for opioid use disorder. And I'm wondering if some of the response here that they didn't find a program that offered what the treatment that they wanted was they wanted buprenorphine, but it wasn't offered. So in primary care, physicians, physician assistants, and nurse practitioners, they see all of these sorts of manifestations of opioid use disorder. So their patients have overdoses and infections such as cellulitis, infections of the bone, septic emboli, infections in their eyes, of their heart valves, HIV, and hepatitis C. Now, one of the statistics here is that within 1 year of starting injection drug use, about 32% of people become positive for hepatitis C, whereas within 5 years, 53% are positive. And one of the other important things on this slide here is that there's an increased mortality rate among people who are using opioids. It's 6 to 20 times higher than the general population. So it's a very deadly disease. Now, there are pharmacotherapies that we can use for opioid use disorder, and providing pharmacotherapy can help reduce cravings and stabilize people's coping capacity, so they're not always focused on wanting to use drugs because the medication helps with the cravings. And then they can focus on their behavioral therapies. And if they're on a pharmacotherapy, it can increase the length of period of abstinence. They end up having an increased sense of self-efficacy, and that can help sustain their recovery. And also, they're going to have, if they're not using, it's going to have a decreased impact on their loved ones. Now, the medications that we have for opioid use disorder have evidence to decrease opioid and injection drug use, also reduce the transmission of hepatitis C and HIV, decreasing criminal behavior, retaining people in treatment, decreasing overdose risk, reducing sexual risk behaviors, and improving physical and mental health functioning. Now, this is looking at buprenorphine. The study was done back in 2003, and what they were looking at is the ability for buprenorphine to retain people in treatment. And they started out with 20 people in each group, the buprenorphine maintenance group and the control group. The control group received a 6-day buprenorphine taper, and then after that they received placebo. Both groups had to go to the clinic daily to dose, even to go and get the placebo. They also engaged in relapse prevention counseling. And what you see on this graph is that there's a quick fall off of the control group, the people who weren't receiving the buprenorphine. By 50 days, all of them were out of treatment, whereas about 75% were retained in the buprenorphine group for that year. And retaining people in treatment is very important because if they drop out of treatment, they're not getting any treatment, and they can't it's harder for them to stay into recovery. One of the important things about this study, too, is that in this control group, 4 people overdosed and died, whereas in the buprenorphine group, there were no overdose deaths. So who's prescribing buprenorphine in the United States? There was a study that was published back in 2015 looking at physicians who have DEA waivers to prescribe buprenorphine. Now, this is before there was an ability for nurse practitioners and physician assistants to prescribe buprenorphine. And what you see, they divided the areas of the country up into metropolitan, adjacent to metropolitan areas, or micropolitan, or small and remote rural counties. And what you see is that of the physicians who had a waiver, 90% were in a metropolitan area, whereas in the smaller towns and counties, there were only 1.3% in those rural counties, or in these micropolitan areas, 2.3% of the certified buprenorphine prescribers are in those areas. And there's also a large percentage of counties that don't have a physician with a buprenorphine waiver. So people would have to travel to another county, maybe several counties, to get treatment with buprenorphine. And you see the highest percentage is of people who don't have a physician, or counties that don't have a physician with a waiver, are those small and remote rural counties. So 82.5%. And this is just a map of those results. And you see people with buprenorphine waivers tend to be on the coasts, and then we have this big dearth in the middle of the country. So another study was published back in 2015 looking at who does have that DEA waiver. And looking at the number of physicians, only about 18,000 had a data waiver. And that was 2.2% of the physicians in 2012. And of those 2.2% of the physicians who have a waiver, 41.6 of them were psychiatrists, and 36.7 were family or internal medicine. Now, looking at the rate of each specialty who has a waiver, psychiatry has the highest rate of their physicians having waivers. The next is pain management, then physiatry or physical medicine rehab, family medicine is down at 3.6%, and internal medicine is 2.1%. So there's room for the primary care specialties to increase their waiver capacity. Now, what happened, back in 2016 was that a new rule was passed. They thought, well, we need more people to prescribe buprenorphine, and how can we get more buprenorphine prescribed into the community to help this opioid crisis? Well, they thought maybe if we increase the number of patients that a provider can prescribe to, that will help. In the first year after getting a buprenorphine waiver, a physician can prescribe to 30 patients, and then following 1 year, 100 patients. And if there's, they can get special qualifications to increase their waiver. Now, what they ended up doing is they increased it for qualified physicians to treat up to 275 patients, thinking this would help get more people into treatment. And to get that 275 waiver, you have to have been treating 100 patients or up to 100 patients for the 1 year. And then you can get this waiver for 275 by having board certification in addiction medicine or addiction psychiatry, or by qualifying in a qualified practice setting. And there's a list of conditions that must be met for that. But I don't know if that was necessarily the problem, that people were at their limit, their 30 or 100 patient limit before that 275. This study was published back in 2016, a couple of months after that final rule was passed. And what they did is they looked at the 7 states with the most certified prescribers, and they said, let's look at the census of buprenorphine patients that they have. And what you see here is that for all of the prescribers that they looked at, there were 3,200. The median monthly patient census for buprenorphine was 13. And in Pennsylvania, there were 18 on a physician census. Massachusetts was the highest with 22. And over the years, though, people started prescribing more or having higher census. And the median episode of treatment duration was 53 days. Now, that's pretty short. It's only about less than 2 months, when what we recommend for treatment is at least 12 months. And this is just looking at those data from that study in a little bit different way. So they had physicians who had 1 to 3 patients, 22% of them. So only seeing up to 3 patients in a month and prescribing buprenorphine. The largest was the 4 to 30, and the next 31 to 75, and only 9% of the physicians who responded, or physicians in that study, had more than 75 patients on buprenorphine. So one of the other strategies that has been tried now to help increase buprenorphine prescribing is by giving advanced practice nurses and physician assistants the ability to prescribe buprenorphine. And so this was passed through the Comprehensive Addiction Recovery Act back in 2016. So for nurse practitioners and PAs to be able to prescribe buprenorphine, they have to do a 24-hour training, and 8 of those can be the course that physicians traditionally were taking to be certified prescribers. And they have to follow the 30 and 100 patient limits. And if the state law requires it, they have to work with a qualified physician as a supervisor. So some data that I'd gotten back in late last summer showed that the number of certified nurse practitioners was about 2,500, and physician assistants about 680. So nurse practitioners and physician assistants, within the year of the CARA being passed, really stepped up to the challenge. Now, one of the things is that we have people going to outpatient care. In 2015, 990.8 million ambulatory care visits were in the United States, and 51.2% of these visits were to primary care. So primary care providers see the largest number of outpatients, and therefore they have the opportunity to provide treatment and have an impact on this opioid epidemic. Now, primary care providers are already doing some substance use treatment. These were some data from the National Ambulatory Medical Care Survey, statistics back from 2010. And when looking at medications that were used to treat substance use disorders, so this could be medications for alcohol use dependence, or alcohol dependence, and opioid use disorder as well. And so you see of the medications that were prescribed, 44% were prescribed by general and family practice, 20% by psychiatry, and then 35% by other specialties. And the patients' individual PCPs wrote about 32.5% of those prescriptions, and about a third were referred to some sort of behavioral treatment. So we have a whole list of medications that are available for treatment for opioid use disorder. Methadone is available in qualified opioid treatment programs. Buprenorphine, Naloxone is available for physicians who have a data waiver. And then naltrexone can be prescribed by any physician or nurse practitioner, a physician assistant. And that is the medication that blocks the opioid receptor. And today we're just going to be focusing on buprenorphine and buprenorphine naloxone. So as I had mentioned about the Drug Addiction Treatment Act, this was passed back in 2000, and this allowed physicians to treat patients with opioid use disorder with Schedule 3 through 5 drugs if they were approved by the FDA for treatment of opioid use disorder. So you can't use other medications like tramadol to treat opioid use disorder, or you can't use hydrocodone, keep somebody on hydrocodone maintenance for opioid use disorder, et cetera. And because it's Schedule 2, you can't use methadone outside of the licensed opioid treatment program. And then in 2002, the FDA approved buprenorphine and buprenorphine naloxone for treatment of opioid use disorder. Now, buprenorphine, this is what we call a partial mu-opioid agonist, which means it binds to the opioid receptor only partially, whereas other opioids like heroin, oxycodone, they bind fully to the receptor. And buprenorphine has a very high affinity for the opioid receptor, so that means a very high liking. It will stay on the opioid receptor. It has a stronger attachment, basically, than other opioids, such as heroin or oxycodone. And it also has a slow dissociation from the receptor, so it'll stay on there for a long period of time and come off gradually. Now, partial agonists, especially when we're talking about mu-opioid receptor, they're going to have only partial effects. And so this is safer when you're giving an opioid because it'll end up having what we call a ceiling effect for things like respiratory depression. So when you take a larger and larger dose, it doesn't result in a larger effect. At some point, it's going to level off, and you're not going to get more and more of an effect from the drug. And that's why this makes it a good medication for treatment of opioid use disorder. Now, we add naloxone in with buprenorphine to help prevent people from abusing this medication. Now, naloxone is the opioid antagonist, so a blocker. And we use naloxone to reverse overdoses. But in this case, we're putting it in the medication so people will not abuse the medication by dissolving it and then injecting it. Now, if people are dependent on opioids, they have physiological dependence, and they dissolve buprenorphine naloxone mixture and then inject it, it should put them into withdrawal. So this is meant to deter people from doing that. Now, if they take the medication under their tongue as directed, then they're not going to have an effect from the naloxone because it's only about 2 to 10% bioavailable, meaning only a very small amount gets into the system. Now, the preferred formulation of buprenorphine is the buprenorphine naloxone because of that abuse deterrence. And this is just looking at the effects of opioids. So you can see that what I was talking about being that partial agonist. You take the medication, and then after a while, you can keep taking it, but it's not going to have more of an effect. Whereas other medications like methadone, oxycodone, or heroin, if a person uses those, they will get more and more of an effect, and that can end up being fatal. And then we have the antagonists like naloxone or naltrexone, which don't have an effect at the opioid receptor. They just block it. So there's several different formulations of buprenorphine that are available since 2002 when the Suboxone and Subutex were first approved by the FDA. So there's a generic buprenorphine tablet. That's the one that's commonly known as Subutex. And then there's a generic buprenorphine naloxone tablet that's out now. And then there's what everybody kind of knows about Suboxone, which comes in a film. You put it under your tongue, or you can stick it on the side of your cheek. There's Zubsolv, which is a tablet as well, and it's supposed to dissolve more quickly than the old Suboxone ones did and these generic ones. And then there's Bunavil. This is a film that you put on the inside of your cheek and let dissolve. And while it's dissolving, you can talk and do things as you normally would, whereas, with Suboxone, you have to be quiet while it's under your tongue. Then there's Probufene, which are some rods that get inserted into the arm and then release medication slowly over 6 months, and we'll talk a little bit more about that. And then there's this new medication that came out too called Sublocade, which is a long-acting injectable medication. It's injected under the skin and the abdomen, and the injections are every month. So here are the dose equivalents for all of these different formulations that can be taken under the tongue or on the inside of the cheek. And so originally when buprenorphine came out, it was in an 8 milligram and a 2 milligram strength. And so we kind of tend to think of the medication in terms of those and then do conversions or what's the equivalent in these newer medications here. So the buprenorphine naloxone mixture is always in a 4-to-1 ratio, 4 milligrams of buprenorphine to 1 milligram of naloxone in this Suboxone. It's a little bit different in this Zubsolv and in the Bunavil. And so the equivalent doses that people will be on are, if they're on typically 8 milligrams of Suboxone, then it would be a 5.7 of the Zubsolv or a 4.2 of Bunavil. And then you see there's a big dose range here too for the Zubsolv, which some people can get on the equivalent of 1 milligram of buprenorphine, and a common dose 16 milligrams is just in one tablet. So to start somebody on buprenorphine, they need to be in opioid withdrawal, otherwise you risk precipitating withdrawal. And that has to do with the way that buprenorphine works in the brain. So it's going to go in, when somebody takes buprenorphine, it's going to get into the brain, and it's going to compete for those opioid receptors. Now, if somebody was recently using heroin, the buprenorphine is going to go to that receptor and kick that heroin off the receptor, but because it only partially binds to the receptor, a person's not going to get the full effect that they had with the heroin or other full opioid agonist medications. So people experience that as withdrawal because they're not getting the same effect, and they kind of they feel that dissociation of the heroin. So when somebody starts on buprenorphine, they need to be monitored with an opioid withdrawal scale to make sure that they have enough withdrawal to be able to start the medication. Now, typically, we do induction with about 4 to 8 milligrams of buprenorphine in the first day, and then the dose can be escalated second day, third day, or within a matter of 7 days. People are on a stable dose typically within a week. One other thing about induction is that there's office-based induction where the patient will come and then they're given the medication, monitored for a couple hours to make sure that they're not having withdrawal, and then they can be given another dose if needed and then sent on their way. And there's also more commonly home inductions where people are given a scope, they fill it, they take it home and do the induction, and then they have some phone assistance to make sure that they're not having precipitated withdrawal or they're having instructions, as to how to increase their dose. Now, in the trainings to be certified as a buprenorphine prescriber, they're addressing the home inductions, and I believe that they're supposed to start addressing, they're doing office-based inductions, and they're supposed to be starting on home inductions. Now, once somebody is prescribed buprenorphine, they typically come to the office on a weekly basis to start and get a 1-week supply of medication at a time. Typically, people give urine specimens at each visit to make sure that they're taking the medication and also to monitor for any other substance use. And they usually have to do some form of counseling. A lot of times this is an insurance requirement, if not a program requirement. And when stable on the medication, so they're adherent to all their counseling, their urines are negative, they're taking the medication as prescribed, then treatment can be advanced, whereas the patient will be getting a 2-week supply of medication at a time. Now, if a patient has a lapse onto opioids or other substances, then they can resume weekly visits with the physician or PA or nurse practitioner. Now, things are a little bit different with these other forms of buprenorphine. So there's the implantable buprenorphine, which is that Probuphine. And what that is there's actually it's 3 rods implanted in each arm. And they're the equivalent of 80 milligrams of buprenorphine. And this medication is meant for people who are stable on 8 milligrams or less of buprenorphine. It's not for somebody who's just starting out in treatment or somebody who's still actively using opioids. Now, these are implanted and removed by someone who can perform minor surgical procedures. And after 6 months, they're removed, and new rods can be inserted into the other arm. And now this newer medication, this long-acting injectable, with that, how that started is a patient gets on the transmucosal, so either the sublingual or the buccal film, and they're on that for at least 7 days before they convert over to the long-acting injectable. And the way that you prescribe this is 300 milligrams sub-Q for 2 months. And so this goes under the skin in the abdomen, and you rotate sites like a clock, so there's in each quadrant. And after those 2 months, the dose is decreased down to 100 milligrams monthly. Now, say a patient is having a problem, they're still using, they have a positive UDS, or they're reporting that they're using, you can increase the dose up to 300 milligrams again. Now, the minimum time between injections is 26 days. And after 4 to 6 months, a patient will be in steady state with that medication. And that's important for something, if somebody's going to stop those medications, this Sublocade, they might still have buprenorphine detectable in their plasma for up to 12 months later. So it takes a long time to get out of the system. Now, if somebody misses a dose, it's recommended to give the dose as soon as possible. Now, up to 2 weeks delay in receiving that dose might not have a clinically significant impact, but it may. In terms of, patients are expecting to get this medication every 4 weeks, and then psychologically, they might start be thinking, I don't have this medication in me, because the mind is very powerful, and then they might start wanting to use, they might start having more cravings. So those could all be problems if they aren't getting their injections on a regular basis. Now, lastly, there's not really any studies so far on the correlation between the plasma concentration of the buprenorphine and the urine concentrations. So we can't really look at any data yet about, what's in the plasma and what's in the urine and how is that important. So there have been some studies looking at what are some barriers to prescribing buprenorphine for primary care providers. This one study, what they did is they provided training for 120 physicians to receive their buprenorphine waiver in Washington. And then they surveyed them 7 months after taking the course. And they had 92 responses, but for odd reasons or different reasons, only 78 of those responses were included. Now, when they asked, so they had that data waiver training, and then they asked how many of you have obtained your waiver since completing that training. Only 50 or 64.1% had obtained their waiver, even though they were qualified. And out of those people who obtained their waiver, 22 of them started prescribing buprenorphine, so that's a low percentage there too, only 28%. And when they found out who was prescribing the buprenorphine, 21 of them were family medicine, and 1 was a psychiatrist. And one of the things when somebody gets certified to prescribe buprenorphine, they can ask, or they can put their name on the treatment locator on the SAMHSA website so people can find them if they're looking for treatment. And only 9 of those physicians put their names on the SAMHSA website to make themselves easy to be found for people seeking treatment. Now, they asked the people in this study what were some of the barriers to prescribing buprenorphine, and then they divided it up into who was prescribing buprenorphine, the light gray, or the black who hasn't been prescribing the buprenorphine. And so some of the response was, lack of treatment needs. So the people who were prescribing the buprenorphine responded less often with that. And then lack of confidence. So those people who weren't prescribing were less confident about their prescribing ability. And I don't know if that's because maybe if they had some more practice, they would have been as confident as the other group. And then lastly, there were concerns about psychosocial support for these patients. And you see actually the people who were prescribing buprenorphine responded yes more often than the people who were not. This was another study looking at barriers that rural physicians specifically face. So they surveyed physicians in rural counties about buprenorphine. And one of the largest concern amongst all groups was concerns about diversion or misuse of the medication. But following that is worries about not having psychosocial support, time constraints, and then concerns about reimbursement. Now, if people were already prescribing, there was some differences between these groups. So you see a big thing here, resistance from a practice partner, that was higher in these people who weren't prescribing or that used to prescribe and then stopped prescribing versus those who are currently prescribing. Same kind of thing goes for patients or physicians who are accepting new patients. They weren't as worried about having lack of specialty backup for complex problems as the never prescriber and former prescribers. So these are all different reasons that people gave, very legitimate reasons, when you're out practicing in a rural area. So there are a couple of models that have been developed over the years by different practice groups. Now, the first is this nurse care manager model in Massachusetts. And what this is it relies on the nurses heavily to help with the management of buprenorphine practice in a primary care setting. So in this model, they have a program coordinator, and this person was a medical assistant previously, and he or she was trained to collect standardized intake info to make this process easier and less cumbersome to the physician prescribing. And then there was a nurse program director who was reviewing the intake that was done by the program coordinator, and then they triaged the patient to either a nurse care manager and a physician to intake appointments or other treatment options, for example, methadone maintenance. And then nurse care managers, which are nurses, completed a one-day buprenorphine trainer to be qualified to do this role. So you see all the responsibilities that these nurse care managers had here. They followed the treatment protocol and performed patient care roles. And so in part, they assessed people for the appropriateness for office-based outpatient buprenorphine treatment and educated the patients. They got informed consent from the patients. They developed their treatment plans. They oversaw the medication management. If the patients were struggling, they would refer them to other addiction treatment. They monitored them for treatment adherence. And then they communicated with the prescribing physicians, addiction counselors, and the pharmacists. So they coordinated their care. And one of the things that the physicians did in this was they wrote prescriptions with refills on it. And that's why the collaboration with the pharmacist was important, because they had multiple refills on the buprenorphine, so they wouldn't have to write scripts as frequently. And then if a patient was non-adherent or dropped out of treatment, then the nurse care manager would cancel those refills. And what was the physician role or the prescriber's role? So they reviewed and supplemented the nurse care manager assessments that were done. They looked over the lab results, they performed the physical exam, and they were the prescribers of the buprenorphine. And they saw the patients at least every 6 months, more frequently if needed. But you see, every 6 months is not that cumbersome for a primary care physician, whereas if, with these nurse care managers involved, otherwise, it would require somebody to see a patient like every week, every couple weeks. And if a patient had complex psychiatric problems, they would co-manage that patient with a psychiatrist. And so they developed the 3 stages of treatment. So during the first stage, it was where the nurse care manager and the physician did an assessment for the appropriateness of the office-based buprenorphine and intake evaluations. Now, the nurse care manager supervised the induction procedure with the buprenorphine and the stabilization, and we'll talk a little bit more about that. And then they also had a maintenance phase where they just were on buprenorphine maintenance, and they were monitored for their illicit drug use and their counseling adherence. And sometimes if patients were not adherent to treatment, they would be discharged. So the physician wrote the prescription for the buprenorphine, and it followed a pretty standard induction protocol. And during this induction, the nurse care manager gave the medication to the patient and then observed the patient for signs of opioid withdrawal. So first they'd review if they had any kind of opioid withdrawal prior to giving the buprenorphine, which is required. Otherwise, you could be at risk for precipitated withdrawal. And then after the dose was given, they monitored the patients for symptoms of precipitated withdrawal. Now, in this office, their physicians weren't present during the induction, but they were available by pager. And patients had the stabilization phase, and these are days 2 through 7, and they took the dose at home. They weren't at the office getting these doses of buprenorphine. And the nurse care manager would call the patient to assess them for withdrawal and then give them instructions on how to take the medication. And they would also ask them about side effects. And then they made dose adjustments based on what was reported by the patient. And then within 1 week, the patients had to follow up with the nurse care manager. During that maintenance phase, they did weekly follow-up with the nurse care manager, and they did this for at least 4 to 6 weeks, and then they could be moved to every 2 weeks if they were adherent to treatment. Now, if they weren't adherent, then they would stay on weekly nurse care manager visits. And at each visit, they had a urine drug test. These typically were unsupervised. Now, if there was something aberrant about the urine, then they could get supervised urines. Now, if the patients were seen less than monthly, like every 2 months, they had what were called random callbacks. And these are to help make sure that people are not diverting the medication, also to do a random urine on them. Because if they know if they're coming into the office to give a urine, it might be easier to kind of work around that in terms of giving a specimen. So if somebody had an unexpected urine result, for example, it was positive for an illicit substance or it was negative for buprenorphine, they were called to meet with the nurse care manager within the next week. And if they were non-adherent to treatment, they weren't doing their counseling, they had positive urines, they weren't taking their medication, treatment was intensified. So they could come in and have to dose in front of the nurse care manager 2 to 3 times a week. They would have increased counseling requirements, et cetera. And all patients were encouraged to attend mutual support groups, and they had mandatory weekly addiction counseling. Now, patients were discharged if they weren't adherent to treatment. So if somebody was having trouble with continued use or they need more structured care, they'd be referred to methadone maintenance treatment. And then if they declined that referral to methadone maintenance, then they were involuntarily discharged. Same thing would happen if they had disruptive behavior at the practice. And patients could request to taper off of buprenorphine at any time. However, they were encouraged to wait at least 6 months to help them with their recovery more long-term. So these are some of the results from this practice. So they were doing this in the mid-2000s. and they looked at data for 5 years. And this was 12-month outcomes for people who were in that office-based opioid treatment practice. And you see that they had good retention. About 51% were considered successful treatment. And, there were 49% that were retained in treatment, and then 2% tapered off after 6 months of being adherent to treatment. And they had 42% that they considered unsuccessful treatment. They were either lost to follow-up, they weren't adherent to treatment, they got discharged due to disruptive behavior, or they stopped taking it because of side effects. And then they had 6% that were transferred to methadone maintenance. Now they were not considered successful or unsuccessful, it was just a transfer. And looking at the urine drug tests for those 12 months, you see that they had very good high percentages of negative urines. So the total number of negative was in the 90%, at 3 months, 6 months, 9 months, 12 months. And they also had cocaine listed here, and those were also negative too, because there's a high comorbidity between cocaine and opioid use. So that's one model that can be used in primary care to reduce the prescriber's burden of caring for these patients, and that's often one of those cited barriers to providing buprenorphine treatment. Another one is the hub and spoke model, and this is throughout the state of Vermont. Now, Vermont was historically underserved in terms of opioid use disorder. They had their first opioid treatment program open in 2002. And that opioid treatment program only had spots for 100 patients. And they had a high number of people on the wait list to get into this opioid treatment program. And then in 2002, with the introduction of buprenorphine, this helped alleviate some of that. But we saw the same thing, they saw the same thing in Vermont as we see in those studies. Physicians weren't practicing to the capacity of their buprenorphine waiver. They would treat a small number of patients because of concerns, that taking up a lot of time in the practice, not knowing how to handle some of the patients, not having psychosocial supports for these patients. So then the wait list grew for that opioid treatment program to over 2 years, I believe. And they thought, well, maybe we should get a specialized clinic to help physicians perform buprenorphine induction and stabilization. We can treat the complicated patients, and we can treat unstable patients. And so with this hub and spoke model, the hub will do the inductions and then kind of farm the people out to the spokes, the patients out to the spokes, if they're not complicated. If they're very complicated, they could stay at the hub. And or if they are out with a community provider and they become non-adherent, they're struggling, the community provider doesn't know what to do with these patients, they can send them back to the hub. And so there's two-way traffic there. So they have hubs in 5 regions of Vermont, and the spokes were the buprenorphine prescribers in the community. And they can seek out consultation from hub physicians and experts at the hub regarding the screening, induction, referrals. And the idea behind this was that the spokes are going to expand their capacity if they have extra support. And some support that they had for these spokes would be an MAT team, so medication-assisted treatment team. And what that was one full-time provider or nurse equivalent and one master's level clinician for 100 Medicaid patients. So the role of the nurse in that MAT team was to meet with the new patients, review the treatment contract, have them sign consents, arrange for insurance authorization. This can be timely, with prior authorization requirements, arrange for urine drug testing, send buprenorphine refills to pharmacies. They monitor the PDMP, that's also time-consuming, and then overseeing diversion control. So observing the urines, doing random callbacks. And then the behavioral health provider that was in that MAT team, they coordinated the counseling and provided crisis management, also brief supported counseling, and they would assist with some practical issues that the patients would have, like, for example, housing, getting benefits, things like that. and they would coordinate referrals between the spokes and the hub. So the results that they had in this model was that from 2012 to 2016, they had a 64% increase in the number of physicians who were waivered to treat people with opioid use disorder with buprenorphine. So they went from 173 to 283. And the number who were prescribed buprenorphine by individual physicians increased. Now, more than 50% of those spoke providers treated more than 10 patients. And you remember back in that one study where, some people have 3 at any one time. And by September of 2015, 23% had more than 30 patients and 10% had more than 50 patients. So by doing this model, they were able to increase the number of buprenorphine prescribers and the number of patients receiving buprenorphine in the community. And now, indeed, Vermont is one of the states with the highest saturation of buprenorphine prescribers per population. Now, as far as other resources that can be used, SAMHSA just published this Treatment Improvement Protocol Tip 63, and there's several different sections in there about using medications for treatment of opioid use disorder. And there's also this technical assistance publication, the Clinical Drug Testing in Primary Care. It gives a lot of information about doing urine drug testing. And the clinical guidance for treating pregnant women and parenting women with opioid use disorder and their infants, that just was released by SAMHSA, I think, in February. And that has a lot of helpful information, too. Other resources that can be utilized are the PCSS Now website. This is the Prescribers Clinical Support System. It's through a federal grant through SAMHSA. And on this website, there are webinars that are either upcoming or they've been archived from the past. You can do buprenorphine waiver training, either online or sometimes they offer live trainings. There's also clinical coaching, meaning one-on-one coaching by somebody who's an expert in the field, has a lot of experience prescribing buprenorphine, naltrexone, et cetera. They also have small group discussions. And then there's other resources such as clinical tools that can be used. And one other thing to look out for is that the American Academy of Addiction Psychiatry received a grant from SAMHSA to provide training and technical assistance on evidence-based practice to combat the opioid crisis. And this is coming to all of the states. It's a big grant, and they're going to have experts in each state helping provide this technical assistance so we can get more people prescribing medications and doing treatment that has been shown to be effective for treatment of opioid use disorder. Just lastly, I'd want to talk about overdose and naloxone. I think that every talk about opioid use disorder needs to include this. So you see, these are some data from last year, or well, 2016, about how many people have been overdosing and dying from drug use. So the top thing is synthetic opioids other than methadone, so that's largely fentanyl. And you see how that's spiked over the last few years. And then heroin, that's increased since 2010. And then you have the natural and semi-synthetic opioids. So morphine, oxycodone, hydrocodone is the next. And then cocaine is in there too. Cocaine, we kind of forget about that. Those cause people to die, as well as methamphetamine, and then methadone. And some of those deaths from methadone, those are from pills that have been prescribed for pain, not from opioid treatment programs necessarily. Now, risk factors for overdose include using more than 100 milligrams of oral morphine equivalents in a day. And there are some studies that show that using over 50 milligrams also can be deadly. Somebody being recently released from a controlled environment. So if somebody was incarcerated, somebody's in a treatment setting, for example, they're in the hospital for a long period of time for treatment of endocarditis, they're not on any opioids, they're just receiving antibiotic medication, and then they leave the hospital, use the same amount, then they're at an increased risk for an overdose. Or else treatment at a drug and alcohol facility where they're not on a maintenance medication. people who mix opioids with benzos, alcohol, and other drugs. Somebody who uses alone is at an increased risk just because there's nobody around to save them if they do have an overdose. And then having comorbid medical conditions such as kidney disease, liver disease, lung disease, HIV, those increase risk for overdose if somebody's using opioids. And then smoking is another risk factor. Naloxone is available for bystander administration. Most states now have laws about third-party prescribing, or there's states with clinical pharmacist, collaborative pharmacist agreements where pharmacists can initiate treatment, similar to how pharmacists can initiate treatment for flu shots or shingle shots. And so the availability of naloxone is out there, and there's also increased education for providers to prescribe naloxone. So there are different formulations. So there's the intramuscular formulation. This is what was around first, where you drop the naloxone in a syringe and then inject it into a large muscle, such as in the thigh or in the shoulder area. And then there's this newer medication which talks to you and gives you instructions, and it's injected into the thigh. And then there are two different intranasal formulations. So there's this one, the Narcan, where you can put the nasal adapter on there. And that's off-label use. It wasn't meant to be prescribed that way originally, but it's an effective way to reverse overdoses. You spray half of this vial into one side of the nose and then the other half on the other side. And then there's the Narcan nasal spray, which is all one piece. You don't have to put anything together or drop anything in a syringe. You just put it in the nose and spray. And all these things should come in a 2-pack, so if the person doesn't respond to the first dose, then you have a second dose to give in 3 minutes. Now, there's a lot of information on prescribetoprevent.org about prescribing naloxone, about overdoses, et cetera. Okay, so that's all I have for the slides, so we have time for questions and discussions.
Thank you so much, Dr. Kamick, for sharing all of your expertise with us. Right now, we only have the one question, but I encourage people, while we're talking about this one, to share any questions that they came up with throughout the presentation. The question that we do have is, and this was in reference to the nurse care manager model that you were talking about earlier.
Yes.
Would patients being referred to methadone be referred primarily due to the need for increased monitoring?
Well, from that, yes, that's one of the reasons that they would refer people for methadone maintenance, because they needed the structure of the program, they needed the monitored daily dosing, or else maybe the buprenorphine just wasn't the right treatment for those patients. They continued to use, still had cravings on the buprenorphine. So those were all different reasons that they gave for sending them over to methadone maintenance.
All right, thank you. We have a couple more questions coming in now. Thank you to our attendees. One of our viewers says they'd like to know more about best practices for integrating Narcan scripts and education into opioid use disorder treatment / general primary care, and resources for free Narcan, as she serves many uninsured patients.
Yeah. Well, the recommendation now is to co-prescribe naloxone with opioids. So offering that prescription to people, if you're prescribing them, for example, oxycodone, you know, somebody broke their leg, for example, and you're going to prescribe oxycodone, you can co-prescribe naloxone with it. Also, the recommendation is that naloxone is co-prescribed with methadone maintenance with people on naltrexone or people on buprenorphine, because they have a chronic disease. You know, they could relapse at any time on their medication or use another medication that lowers their respiratory drive, such as benzodiazepines, and put them at risk for an overdose. So the other thing is if a patient requests naloxone, it should be prescribed, or if they request it for themselves, or if they're concerned significant others. And that's going to vary on people's states. You know, if you have a third party prescribing for naloxone, I know that's becoming more common with the current state of the opioid crisis, that you can prescribe to a concerned significant other. Similarly to if somebody had a sexually transmitted infection, you can give that antibiotic out for them to give to their partner. As far as free resources, I'm not, you know, it's going to depend on where you're located. Sometimes the counties might have some money, and with these things like the 21st Century Cures Act, the CARA was supposed to help integrate or increase naloxone distribution, and the Cures Act is what I believe the money that would fund the things in CARA came from. So some states have money that they're giving out to help with naloxone, and if you're seeing patients and you're in probably more of an urban area, you might have a harm reduction program that gives out free naloxone. I know here in Pittsburgh we have Prevention Point, where if somebody goes and they want to get naloxone, they can get it for free. We also have naloxone at the health department, and it might be at reduced cost. So that might be a resource or two for you to use for patients who are indigent or don't have any kind of insurance.
All right, thank you for that detailed answer. Do you have time for a couple more questions?
Sure, I just realized I went over a little bit with my talk, so if there's any other questions, yeah.
That's perfectly fine. Another viewer asks, can you speak to the patient experience of using the injectable or insertable rod forms of buprenorphine, and how is this tolerated?
Well, honestly, I don't have any experience with those yet. Okay, so the rod ones, we're not doing those at our clinic, and I'm not sure, you know, patients might like that because they don't have to come in regularly for the medication and fill the medication regularly. And for stable patients, that could be a good thing. I do have a colleague who was prescribing them, and she had those patients kind of drop out of treatment and didn't see them after the rods were inserted. So that could be a barrier, you know, that somebody has in prescribing those. But they would be good for a busy practice, though, because you don't have to do as much writing of prescriptions and things like that. But I'd suggest still doing monitoring, too, to make sure that somebody doesn't go into relapse while they're on that medication, you know, with urines, and also requiring some addiction counseling. As far as that new one, the extended release buprenorphine injection, that one we're just working on the processes now to get that in place at our clinic. It is only available through certain pharmacies. It's restricted distribution, so you have to work with pharmacies on that. There's a lot of things that the manufacturer has put out to help prescribing with that. So, you know, getting authorizations and stuff with these specialty pharmacies is available. Now, I have talked to some patients about starting this medication, and actually I did just this morning, and he said he likes to take the medication daily and doesn't know, you know, so what happens when you inject this is it's in this matrix that becomes a kind of a gel, and then it releases the medication slowly over the course of a month, and he didn't like that idea. Now, I suspect some patients aren't going to like this idea because they like having control of their medication. They might not be taking it all as prescribed at times. I'm not sure, but it could simplify treatment for some people. They don't have to worry about taking it every day, and also reduce relapse risk because they have this medication on board. You know, one of the problems that, you know, we worry about as providers is that people don't take the medication that they use, and so you can kind of just, if you're thinking, hey, I might use heroin today, just don't take the medication. And so it's a good medication for those patients, I would think. So, yeah, research other than what's been presented to the FDA, I'm not really aware of at this time. as to how it is now clinically, because it just came out.
All right. Our next question is, what do you recommend if a patient has an acute trauma and needs an opiate?
Oh, well, yeah, patients with opioid use disorder do develop pain, and so it's expected that sometimes, they might need an opioid medication. For example, we have women who are on buprenorphine that have cesarean sections, and they might be given oxycodone, for example, or if somebody does have a fracture, they might need that. So what we do typically during that time is patients, depending on their dose, they can either be continued on the dose and given an opioid on top of it. They could stop taking the buprenorphine and then take the opioid short term. But I've increased the monitoring during that time to make sure that their use of that opioid doesn't precipitate a relapse onto opioids and then they're lost to treatment. So following them closely, asking, if they want somebody to administer their medication, they have a concerned significant other that can hold on to it to make sure that they don't lose control with the medication can be helpful. And so following them closely with the urines as well as their counseling during that time.
All right, thank you. Looks like we just have one last question today. One of the attendees wants to know your opinion on whether prescribing naloxone to people in treatment might communicate the message that that it's still okay to use and that this might hinder some individuals' treatments.
Well, that's a concern a lot of people have about, what message is it giving, if we give naloxone to people who are in treatment for substance use disorder. But I think what it speaks to is that we're concerned about their well-being, and we know that addiction is a chronic disease, a relapsing disease. So people could stop either if they're in a treatment with no medication or if they're in a treatment with medications such as methadone, buprenorphine, naloxone, that they could have relapse at any time, and that puts them at risk for having an accidental overdose. And what I typically say is that, it's for safety. And because most of the patients that I have, they say, I don't want to use again, I'm not planning on using again, I don't really need this medication. And I talk to them about it being similar to a fire extinguisher. I have one in my house because, I don't want to have a fire, I'm not planning on having a fire, but just in case, I need that fire extinguisher for safety because it can save a life. And so if patients don't want the medication, you can always tell them how they can get it in the future too. But the studies haven't borne out that people who are prescribed naloxone are using more or are using in a manner to, put themselves at risk for an overdose. It's just there as a precaution, and until, this can also help people get into treatment later, right? If we can't help anybody who's dead from an overdose, so this is something to help bridge them, because sometimes people aren't, there's different stages of change. Some people aren't ready to stop using at the time, so giving them that naloxone can be helpful and facilitate them getting into treatment.
Okay, thank you to all of our participants for listening and for sharing such thoughtful questions. And thank you very much, Dr. Kamick, for this great webinar.